Good afternoon. Thank you for staying, whoever stayed, to join me. I know that we have an event tonight, so I will try to do a good job by finish on time. I'm going to talk about contrast-enhanced mammography. And I do have to disclose my research collaboration with GE. And I'm going to talk about the clinical use of contrast-enhanced mammography, the limitations of this technique, and management of abnormalities detected by contrast-enhanced mammography. Just a reminder to whoever doesn't know it by now, after so many times you heard it today, contrast-enhanced mammography is composed of two sets of images at high energy and low energy. And when we are coming to review the images, we are looking at the recombined view, which is a subtraction of the low energy from the high energy, as well as the low energy, which is equivalent to that of standard mammogram. So contrast-enhanced mammography diagnosis must rely on both low energy and recombined views. If we're not doing that this way, this is a big mistake, and we're going to miss abnormalities, and I'm going to show you why. The performance of contrast-enhanced mammography was initially investigated in the setting of diagnostic imaging, and initially comparing the performance of contrast-enhanced mammography to that of standard 2D digital mammogram, as well as tomosynthesis. Few views were done on tomosynthesis. And the most important thing that all studies and the follow-up studies that after those were showing consistent results of excellent sensitivity with contrast-enhanced mammography, with some compromising of specificity. More interesting is how the performance of contrast-enhanced mammography is when we compare that to MRI, and when that was done in the diagnostic setting mainly. Again, contrast-enhanced mammography showed to have a very good sensitivity and performance that is very close to that of MRI, with actually improved specificity. So this is, of course, very encouraging. And there are other advantages beyond just the sensitivity and specificity. And one advantage is that contrast-enhanced mammography showing the best correlation in terms of the lesion size on imaging to that of finer pathology. It's also allow a one-stop shop assessment and prevents delay in treatment. Calcifications can be seen at the same time, and we can co-register this information and appreciate even minimal enhancement. It's definitely reported to be better by the patients over the experience with MRI. And of course, there is the low cost of iodine compared to gadolinium, which is non-negligible. So all of these are good advantages. And this is probably the most classic appearance of contrast-enhanced mammography versus MRI, showing that these two modalities are fairly equivalent, but at lower cost and much better availability and immediate availability. So with this excellent introduction to how contrast-enhanced mammography is, I'm going to show you a few clinical scenarios where we can use contrast-enhanced mammography, and really the sky is the limit. The more comfortable we are with this procedure, the more options we're going to discover, and more flexibility if we're willing to change, we're going to discover the more we work with that. Number one scenario is patients who is called back from abnormal screening. In my institute, if we identify a lesion that looks suspicious enough on screening mammogram, or even on the background of dense breast like that, we book the patient for contrast-enhanced mammography upfront, anticipating that this is probably going to be positive. And of course, we can see that not only that it's positive, but also it is way more extensive than we would imagine with the standard mammogram exam. And this is something, you did that, we do that every day. Like this wow effect happens, this is our daily practice with contrast-enhanced mammography. Like every time you do that, and I think I said that already to whoever heard me before, this is a game changer. Every time you do, since we practice contrast-enhanced mammography, the feeling that I don't know how we practice breast imaging until now is out there all the time, because that's a daily practice. Another example, in our institute, we offer patients first ultrasound if they have palpable lump, and then contrast-enhanced mammography if it's positive, or if it is extremely dense breast appearance. So this is a patient who presented with palpable lump, which it was easy to confirm on ultrasound. We knew that this is aggressive, and we just wanted to do staging. The patient felt the left breast. The patient did not feel the right breast. Not only that, this was occult on her low energy views. So this is a completely incidental finding detected by contrast enhanced mammography. And of course, if we see this abnormality, we can do the ultrasound same day, biopsy same lesion same day, and then confirming that. This patient had an MRI for research purposes. And this example, just to show you how contrast enhanced mammography is equivalent to MRI by showing the extent of the disease. And the only thing that we may not appreciate would be the lymph nodes. But we're going to do ultrasound anyway, so it doesn't matter, right? So there you have one appointment, we can solve everything, and this is what happened with this patient. This is a good example because this patient doesn't even have a dense breast. And of course, we can appreciate that there are few asymmetries, yes, on the scattered, but this is scattered fibroglandular densities. And she was called back for that. Look what we discovered. And again, one appointment, we appreciate that there is no abnormality on the left breast. Not only that, just think about the surgeons. We have to think about surgeons, about oncologists who are going to talk with the patients and have the discussion with the patients and plan the surgery. The patient is unlikely to have a mastectomy that maybe she will have oncoplastic surgery, but definitely not mastectomy. If she will have oncoplastic surgery, meaning just the skin and the nipple will be saved, then they definitely need to have a roadmap to know how to go and how to approach that. So this serves them much better. They cannot see an MRI. They cannot read an MRI. They can read that. So that's very, very useful for them. Another typical scenario, patient is being called back, abnormal screen. Everybody can see that, right? Patient has contrast enhanced mammography. We can appreciate the lesion. We can see the lesion on ultrasound. And we can see another tiny lesion. Now, it definitely occult on the lower energy view, but on ultrasound we can find it same day. And now, if we can do the biopsy someday, we can do it. If not, she will come in another day. No surprises, right? No surprises. Everything is booked appropriately and more efficiently. This is probably, in my opinion, the most classic scenario when contrast mammography can be used and should be used even for screening purposes. And this is a patient with history of previous lumpectomy. It is so difficult for us to say based on standard mammogram whether there is just scarring or recurrent disease. These patients usually being treated with tamoxifen, meaning that we don't expect background parenchyma enhancement, everything is going to be so quiet, and discover that she has a recurrent disease. And even in ultrasound, this can be very difficult because there is scarring, the scar tissue will get shadow, but with this, we know for certainty that there is something to biopsy and to look for. Another scenario, patient who has a palpable lump, patient with locally advanced breast cancer, in this case because of lymph node and extensive disease, and we do monitoring for neoadjuvant therapy. We see excellent response, but look what we also see, that someone forgot to put a tissue marker after the first exam. But we have this, so we can localize that under contrast enhanced mammography and still perform a good evaluation of the residual disease. So it saves us in this case. And this is probably another excellent scenario. Patient present with palpable lump. I told you that we start with ultrasound. In this case, the lump was in the axilla. We see that. We examine the other axilla. We see that probably this is not lymphoma. It's probably metastatic disease. We don't waste time. We go directly to contrast enhanced mammography. Low energy does nothing, shows nothing. And we discover this. And now we can do the ultrasound and do the biopsy and confirm the malignancy. No need to send, do MRI, get an appointment, all of this headache. This is an example of a patient who is on dialysis. This is why you see all those calcifications, and this is why you see that the craniocaudal view is not the best, because she has all of the dialysis on the right side. The patient was booked to have a renal transplant, and her dialysis was booked within less than 24 hours than the exam. Therefore, we can give her the IV contrast. Not a dense breast. Surprise. Yes? Cancer, invasive cancer. Not a dense breast. And now I'm taking you to the whole different scenario, which is an asymmetry only, detected on screening mammogram. Do spot views here? Yes, we can do tomo. Did not persist. But the radiologist has, very difficult to send the patient away with such dense breast, even there is nothing there. You do that, you say it's negative. It's so much easier, yeah? Like I had my own contrast enhanced mammography in April. I know that it's negative. I have a peace of mind for another year. I wouldn't have it with a standard mammogram. No way that I would have it. So it buys everybody a peace of mind, which is excellent. Another example, in this case, I'm going to show you an example compared to tomosynthesis. So not dense breast, again. We see an asymmetry, maybe distortion on the standard mammogram. Definitely we see that much better with tomosynthesis, excellent. And a surprise, not only that it's bigger, but there is another one closer to the nipple. And this is not a dense breast. This patient in a normal world would never get an MRI. Nobody will tell me that she would have get an MRI with a breast like that. And surprises still. This is why we do contrast-enhanced mammography for all of our patients with breast cancer. Everyone gets contrast-enhanced mammography because we know that we can see, I showed you patient with fatty replaced, I showed you patient with scattered fibrinoid densities, always helpful. How about screening? We were talking about diagnostic, how about screening? 2 big studies, more than 2, but the biggest studies were published recently comparing the low energy performance to that of the entire mammography exam. And both showed similar results that contrast-enhanced mammography is an excellent modality also to detect patient in a screening, cancers in a screening setting. And in the second study by Sang et al. From Sloan Kettering, 15 for every 1,000 compared to normal mammogram, which is 3 to 5. So with that, the announcement was in the RSNA of December 2019, a second before the big the big explosion of COVID, to start and conduct a study called CIMIST in order to explore the performance of contrast-enhanced mammography. That's in December 2019, and to explore the performance in patients with dense breast parenchyma ages 45 to 75 compared to tomosynthesis and compared to ultrasound. This study conducted by the ACR, but funded by GE. So GE workers, applause, very good job. With the pandemic, everything got postponed, and they decided to, also because it became more complicated, to just compare that to DBT. The study, the first patients was recently enrolled. Our site is going to be part of it, but it is more complicated for us to get the approval. But meanwhile, the study starts to run. So we are going in this study to compare the performance between contrast-enhanced mammography and tomosynthesis, and to determine whether this is also has fewer false positive in patients with dense breast parenchyma. The study will be performed in a patient who are asymptomatic, ages 45 to 74. They can be with personal history of breast cancer or not. So the category C or D that will be eligible. It's going to be the randomized order of reporting, but double-blind study. So 2 readers. One will be randomized to be reading only the tomosynthesis. One will be randomized to read only the contrast-enhanced mammography exam. They will not be aware of the results, and they cannot use the contrast imaging as a reference toward the decision. So it needs to be outside of the contrast-enhanced mammography. The patient will have the study at the first year, like in this case, baseline, and then second year, showing that there is, in this case, developing breast cancer. This is, by the way, not from CIMIST, but this is a screening contrast-enhanced mammography example, showing you the possibilities that we have with screening and contrast-enhanced mammography. The reporting system for contrast-enhanced mammography until April of 2022 was based on the MRI and mammogram lexicon. Since then, there was an introduction of dedicated lexicon. I'm not going to go over the lexicon. You can scan if you want to read it. But the purpose is to distinguish between lesions that are detected only by mammography, for which we're going to describe that with standard 2D lexicon. Lesions that are going to be seen only on the recombined views, and lesions that are going to be seen on both. The differences is that we're going to describe a new entity that is enhancing a symmetry that doesn't exist with MRI because we don't have, it's more than one view image. And, and we're going to talk about the extent of the enhancement for lesions that are seen on both, whether it is within the same extent of the low energy view or below or beyond. There are few limitations that do exist with contrast-enhanced mammography. No good without bad, and we need to acknowledge that. Number one limitation being the background parenchymal enhancement, which can be range between minimal and marked. With that, even on the marked, try to see there are abnormalities that we can still identify, especially if we are comparing that to the other breast. So sorry, I didn't flag that. And this and this. There are actually two cancers here that we could detect regardless the fact that there is such a marked background parenchymal enhancement. We can tailor the study to the patient's menstrual cycle. It's not very realistic in a diagnostic setting. We don't want to put the patient's treatment on hold, but it can be done in a screening setting or in the follow-up setting for patients that we want to come back like BI-RADS 3. In this case, you can see the differences in the same patient when the exam was tailored to her second week of the menstrual cycle. There are definitely false negative exams exist with contrast-enhanced mammography. Luckily, these are low-grade malignancy, more so DCIS and more so lobular type of low-grade malignancy, usually not the high-grade. In this case, the patient had an ultrasound for her palpable lump. You can see that there is an abnormality, obvious abnormality on ultrasound. Very difficult to see any abnormality on the contrast-enhanced mammography exam. And really, just because we know that there is an abnormality on ultrasound, we see minimal area of non-mass enhancement there. Now, but that's the thing with contrast-enhanced mammography. Sometimes, if we see a very subtle abnormality on the lower energy view or on previous or change from previous, we can appreciate that there is a very little enhancement that we otherwise wouldn't appreciate. This can be much more difficult with MRI because we don't have a prior exam for comparison. So there is a strength that comes with that, and this is the availability of prior imaging that sometimes we can appreciate that because of that. This is another example showing obvious distortion, no doubt, on the low energy views with absolutely no enhancement on the recombined view. This is an example of invasive low-grade ductal carcinoma in situ. Now, if we're going to compare tomosynthesis to contrast-enhanced mammography, tomosynthesis will not miss that. But who cares? It's a low-grade malignancy, right? It will take a long time before this will send any metastasis. And the idea is to save life. It's not to find all cancers. So early detection, this is our goal. We know that there are cancers that we are going to miss. This is another example. Again, enhancement, we know also with MRI, DCIS, you see the calcifications, pleomorphic, branching, suspicious. With MRI, it would be impossible to register the enhancement. Here, you can see because of that, there is minimal enhancement on this upper outer quadrant, non-mass enhancement. But we are not doing that to discover that. We're doing that to say that probably we're not missing any invasive cancer. So you can see that the patient has a dense breast. We know that this is not the tip of the iceberg. We don't need to worry about it. It's only DCIS. So we don't really care about this enhancement in reality. False positive also exist. The most common one would be fibroadenoma, our enemies with everything. With MRI, here we see two lesions. With MRI, there is a big advantage. We can see unenhancing septations, and we can see the high T2 signal. Both are very helpful to characterize fibroadenoma. But with contrast-enhanced mammography, the patient is at the department. We can do that's the T2 for the same exam. We can do the ultrasound same day and prove that this is fibroadenoma, so we can overcome this advantage of the MRI. This is another example. This cancer, the patient has this obvious cancer, but look at the medial aspect. There is an area of non-mass enhancement. And it is so much easier with contrast-enhanced mammography because of the low energy view to appreciate that there is fat-containing lesion, just fat necrosis. We don't need to worry about it. And again, comparison to previous is very helpful. Like in this example, the patient had a contrast-enhanced mammography. We see an area of non-mass enhancement, but we had her mammogram from 4 years prior. We can see that nothing changed, and this is really not a suspicious finding. Patient had prior breast reduction. This is just post-surgical changes. So that's the area. This is the nodularity and stability over 4 years. Artifacts is another limitation. Number one being the breast within breast artifact, as you can see here. Nightmare because it can harbor breast cancer. However, GE did an excellent job by eliminating this artifact, thank God. And now we barely see that. So look how, like, we can hide a lot here. But this is now, so you look at that, that's an older, and look at this, we almost eliminated, so much better now. Motion artifact, that's another thing. A patient who cannot tolerate good compression can have that. You can see that this is something that we can solve easily with better compression and improve the image, but still some motion, but much better. Skin folds and scarring, again, they can create some artifact. The contrast, there is no good subtraction at this region, and we may end up seeing some false enhancement, so the technologists are trained to open this area and add additional views. And sometimes stasis within vessels. We know how to get rid of that. The only thing that it might hide something if it's in the breast, so that's the problem. And implants. If there is no good implants displaced views, we might get these artifacts, which is similar to the breast within breast. In this case, there is actually a cancer hidden there that we couldn't appreciate the only reason why we could appreciate because we saw some asymmetry on the low energy view. Again, the diagnosis is made based on both recombine and low energy views and comparison to prior. So by all of that, we can compensate for everything. Managements. How do we manage lesions that are detected by contrast-enhanced mammography? Number one is if we see the abnormality, we do an ultrasound exam. That's our standard for everything, in mass, non-mass enhancement, we do that. If we see a lesion, we do the biopsy, put a tissue marker, and then do an image to compare post-clip with that and seeing that we're in the same spot. This is an invasive cancer, by the way. If we don't see an abnormality on ultrasound, we can always search for an abnormality on the low energy view. There are some classifications, or in this case, where there is non-mass enhancement, there is a bit of asymmetry with some distortion. This was before contrast-enhanced mammographic guided biopsy was introduced. So for that, we took the patient for standard stereotactic guided biopsy. We didn't have tomobiopsy at that time, so we still managed to solve everything. Vertical approach, under stereotactic, standard stereotactic guided biopsy, tissue marker, and then we can confirm, sorry, I don't have the other view, but we confirm that's that, and this was DCIS, by the way. This is a patient who had an extensive malignancy on the left breast, and we saw this little guy in the medial aspect on the right breast. No lower energy correlation, no sonographic correlation. Very, very small non-mass enhancement. We took the patient right to MRI-guided biopsy. Again, before we had the contrast-enhanced mammographic-guided biopsy option. We see the lesion on MRI, and we biopsy that under MRI, put tissue marker. This is an invasive cancer. And thank you again, GE, for introducing the word with contrast-enhanced mammographic-guided biopsy. Because before that, it was very difficult for people to adopt this modality. So this is an add-on unit, similar to the standard stereotactic guided biopsy, with the only difference is that now we use the software to enable dual energy technology. We can do that with the patient either lying down or sitting in either upright or lateral approach, so either vertical to the breast or horizontal to the breast, as you see here. We do the biopsy. First contrast is injected, then we position the patient for biopsy 2 minutes after. And the way we do that at my institute is first we try to find a landmark before we actually inject the contrast, mark the patient's skin, remove her, do the injection, and bring her back. And usually with one attempt, we usually find the area. But you can do that without that, and you can try, and then you may need 2 attempts. This is the low energy view, and this is the lesion. We target the lesion with the standard stereotactic views, again, dual energy technology, finding the lesion, and then we can biopsy. In this case, this is in pre-firing position, horizontal approach, my favorite approach. This is after the biopsy is done. This is now while everything is during lavage. We like to take this image because we can see where is the opening and to see whether we want to take more tissue from here, for instance, right? So it's better actually to have it with open and while it's lavaging the system, and then deploying the tissue marker. Look that we still see, even at the end of the biopsy, we still see a little bit of enhancement. MRI, lesions detected by MRI. We can now biopsy with contrast-enhanced mammographic guided biopsy. In this case, we elected to do that because of proximity to the implant. With the advantage with contrast-enhanced mammography, we can do implant displaced views. So we did the exam first. I can tell you this was done under a trial that you could have done the biopsy immediately. You don't need this step. Like, there is nothing to lose, right? So this is now at the time of the biopsy. If we wouldn't have this step, we would see that. So it's not a problem, right? So we know where we're going. And this is just fibrocystic changes and fibrosis. Okay, take-home notes. Number one, and I think for me it's always important to emphasize, and it coming from my own perspective, that I used to say, I don't need contrast, we have MRI, I have MRI, I don't need contrast-enhanced mammography. Not true. You need contrast-enhanced mammography even if you have an MRI, because you don't have endless spots with MRI. Plus, there are other reasons, and this is the availability and the immediate treatment that you can offer the patient, so, and diagnosis. You can save those spots to do something else with MRI, do more screening, do more high-risk screening. You know, it's not like you have unlimited spots for MRI. It's definitely, the rapid assessment is a huge thing. And it, as I mentioned, high satisfaction among our stakeholders. In fact, our surgeons and oncologists won't see a patient if they don't have contrast mammography as a baseline, because they monitor for treatment, they monitor for surgery, for everything. So they always get it, even if it's a fatty breast. And now, this is my favorite picture, proving that my husband is a better radiologist than I am, although he's not a radiologist. Because we took a trip to Namibia safari, and my analogy for that trip, the entire safari, by the way, my entire analogy for the safari trip is that this is like practicing breast imaging. All day you're looking for animals, and they're all day hiding away from you. And one good radiologist, which is probably like my husband, saw that right there. Okay, so it's there. And that. But if I had contrast-enhanced safari, that will be the image. Much easier.